So the question is, well, if we think about where disruptive innovation could take this market next, does it simply stop there? Well, certainly, we can imagine with more and more targeted medications, personalized medicine as it's often referred to, we can envision coming up with personalized profiles where we can offer an arsenal of drugs or treatments or preventative measures to keep people from ever needing these interventions in the first place. And that really is the domain of general practitioners. And so armed, again, with the right technologies, we can help these generalists do more and more sophisticated things. And once again, we're moving one circle outward to treat patients ever earlier at a lower cost per case. And we can also envision perhaps these same tests that are being offered today in the doctor's office could be offered by mail or could be managed electronically and put into the hands of patients. And there are a lot of proponents of things like Lipitor going over the counter that say that the benefit is far worth the risks. And so the question is, if we can continue to push along those lines and decentralize the system, really it leads to the most affordable and sustainable healthcare system that we can imagine. Now, one of the big challenges to disruptive innovation is whether or not, in fact, we're replacing good quality healthcare with bad healthcare, or are we, in fact, trying to put doctors and hospitals out of business? And that's a challenge I often get from my colleagues. I still have many friends that work in hospitals, and I'm talking about their livelihoods, and so this is a big concern. And really, the best argument I can come up with is the fact that what I'm trying to do is shift the work that doesn't utilize your talents into areas where people are able to do more sophisticated things more affordably. But the idea is not to put you out of business and leave you with nothing to do, but it's to free you up so that you can focus on the things where we really need your help. And one area where we've seen this happening is in the legal world, in the legal profession, which to me is one of the best analogies, of course, in the medical profession. And there, we've seen a number of disruptions where we're trying to take things off of lawyers' plates so that they are free to do more high-value activities. And the whole idea is to automate the automatable. There was a profile of a company I read not too long ago called Basha Systems, and they basically have document assembly software that helps you do things like create real estate leases, and it reduces the time from an average of 40 hours to 1 hour. And because of that extreme efficiency and time savings, they've, of course, grown year after year tremendously for the last decade. But the whole point of the article was not, look at how great Basha is doing and how many lawyers are getting put out of business, but the idea was that it freed up those lawyers who used to do these real estate licenses so that they could actually spend time talking to their clients or focus on higher value work where they could earn more money. And the idea, I think, for doctors is the same. I don't want doctors treating the sniffles or ear infections when those could be done more affordably elsewhere. But I want to free up their time so that they can really talk to their patients and spend time doing the things that really deserve their talents. Now, how disruption actually happens, well, as I've mentioned a couple times now, it starts with this technology. It simplifies what used to be very complex and could only be done by highly trained, highly paid experts. And so when you think about the early days of computing, when you had to build a mainframe computer, there was a lot of intuitive trial and error problem solving involved that, if you wanted to build a working mainframe computer that did exactly what you wanted, you probably built thousands of prototypes before you got one that worked. And as a result, every machine was essentially a custom build, very complicated, very expensive. And that's why you had to be one of the top engineers in the world to even hope to build one of these machines. Now, over time, these artists basically practiced their craft, building mainframe after mainframe, and changed that art more into a science. And you started to approach this era here in the middle that we call pattern recognition. And here you can start to say, well, if I'm going to use component A, it's always got to be fitted with component B, and it'll never work with this other part C. And you can start to teach other people some of these things. And so you no longer had to be one of the best engineers in the world. You still had to be pretty darn smart, but all of a sudden, the number of people who knew how to build, say, a mini computer grew substantially. Now, ultimately, we progressed all the way to the right, where we enter a world we call rules-based work. And in this era, things are essentially plug and play. There are standards that emerge, and all of a sudden, you know exactly the recipe it takes to build something like a PC. And components just snap together and it works. And all of a sudden, when that era emerges, you can have somebody like Michael Dell make a business out of just assembling computers in his dorm room. Now, when we translate this evolution of work over to healthcare, we find that there are stages in the progression of how we understand and treat diseases, where most of our diseases still sit on the left in this era that we've called intuitive medicine, where the diagnosis and treatment is still very much dependent on the highly trained, highly paid experts of that industry. In this case, it would be the doctors. But as, again, these artists practice their craft over and over again, some science begins to emerge, and we start to enter this realm that we've called here empirical medicine, but could also be labeled as evidence-based medicine. Basically this idea where we can express in probabilistic terms that if I give you a drug at this dose, it's gonna work X% of the time. And all of a sudden, again, you don't need to be one of these top 10 experts in the world to be able to know what to do, but you can follow guidelines and provide best practices for your patients. Ultimately, though, what we want to do is drive all the way to the right. And in healthcare, what that translates to is this idea of precision medicine. This overlaps a little bit with this idea of personalized medicine, but it's basically this concept where you can diagnose diseases precisely at the root cause, understand what that root cause is, and therefore apply a predictably effective therapy. If you really understand what's causing the problem, you can treat it predictably. And as an illustration, the things that allow us to move in that direction, at least to empirical medicine, are the evidence that's being generated by clinical trials. And things that are moving us more to the right are things like imaging and molecular diagnostics. It seems like precision medicine might be a ways off, but if you think about things like infectious diseases or even cancer treatment, we've come a long way from the days of describing cancers just geographically, where you might say somebody has bone cancer or breast cancer, and what we're really understanding is that underlying those geographies are actually a number of unique cancers that can be targeted very differently and therefore treated with a predictable efficacy. And not only that, we might find bone cancer and breast cancer, some of those tumors having things in common. So we're redefining diseases, whereas before we could only understand them by what we could observe, and that is to diagnose them geographically. And certainly with infectious diseases, we've progressed to the point where we can not only identify the causal organism, but we can profile their resistance characteristics and give them an antibiotic that's specifically targeted to that profile. So certainly for some diseases, we've approached this rules-based work that we described earlier. And again, as an illustration, we looked at tuberculosis in our book, where the size of these circles basically represents the mortality rates. And we went through the history of tuberculosis where less than a century ago, it was basically lumped under this condition called consumption. And consumption, even though most of those cases were indeed tuberculosis, lumped into it were a lot of diseases that physically overlapped with what tuberculosis was. So we thought some cases of bronchitis or pneumonia or cancer looked like tuberculosis, and we just diagnosed them as consumption. But over time, as we started to understand the underlying cause, that we started to understand that there's a bacteria causing this, and the treatments, we started to understand that there were certain categories of drugs that were effective against this particular organism. We started to move more and more to the top right, where there was a highly precise understanding of the the root cause, and as well as the effective treatments available. And the circles got smaller to the point where we were tracking individuals with multi-drug resistance to ensure that they didn't spread to the rest of the population. And then we expanded this to a map of a larger number of conditions. And certainly we didn't try to populate this with every condition, but just randomly selected ones where we thought ones in the top right were diseases that we understood very well, where we knew the root cause, and we had predictably effective treatments available. And meanwhile, on the bottom left, we had diseases like depression and dementia and chronic pain that were very poorly understood, and most likely, much like consumption, were waste baskets of diseases that we simply lumped together into a disease that probably was made up of a number of diseases with different root causes that had to be treated very differently. But we're not quite at that stage of the science yet. Now, the reason we did this was, first of all, to show people that you have diseases at different degrees of the spectrum, some very well understood, some not so well understood. And depending on where you are on this diagram, you needed different business models to manage those diseases effectively. On the bottom left, you required a lot of that intuitive work, driven by experts. But on the top right, perhaps not so much. At the same time, the other reason for drawing this map was to understand that this map was in flux. So you had diseases that on the top right that didn't start there, but actually moved there from elsewhere. And so understanding that diseases were constantly moving to the top right helped you to understand that there needed to be business models that are ready to catch these diseases and treat them in a more affordable and accessible fashion. And we have a big problem with that in healthcare. That is, when technologies become viable, we don't have business models ready to accept them, and instead we plug them right back into the hospital business model.